This is Lisa Letourneau. We're going to start recording this. So if you do not want to be on a recorded session, now's your time to sign out. Thank you, Amy, for your help with that. And I'll start again. So Lisa Letourneau, Maine DHHS, welcome everybody here with Dr. Stephen Sears and Dr. Peggy Penoyer. Again, for some updates on COVID vaccines. There have been more, certainly since the last time we talked, although we are going to revisit some of the info on the Johnson & Johnson vaccine because it's still new. So as always, if folks want CME, send an email to covidcme.dhhs. And we do not have any financial interest to disclose. In addition to doing a review of some of the information about the Johnson & Johnson vaccine, which they are generally referring to as the Janssen or Janssen vaccine, we have several important updates from the US CDC as well. So we'll be talking about some of those that just hit the news yesterday. So with that, a brief recap of some of the J&J issues. Dr. Sears.
Brief recap. We have two vaccines presently available, viral vector vaccines, nucleic acid. We know nucleic acid is mRNA and Pfizer. The viral vaccine is Janssen. It works in kind of a interesting way. The virus enters in the cell, releases the genetic material for the spike protein. We make spike protein, and our immune system is then activated. A very effective vaccine. The virus does not replicate. The trial was done in about 44,000 plus minus, all over the world in South Africa, and I think that's important to remember that, Colombia, Argentina, Peru, and the United States. Very good representation in populations and in ages, and some about 10% of the people were already seropositive for COVID. Those with known pregnancy were excluded. Next slide. We received the vaccine for EUA from the FDA at the end of February. We've actually started delivering it. It's an effective vaccine in preventing serious and critical infections. It has different efficacy rate depending upon what numbers you look at. Some of that was that this was done in South Africa, where the variant that we know, which tends to be able to be less susceptible to vaccines and immunoglobulins, exists. And this trial was done at different times than the vaccine for Pfizer and for Moderna. But I think the important point is 85% protection against severe disease, 100% against hospitalization and death at 28 days. So reactions are about the same as we see with the other vaccines. And the most important thing is a single dose and doesn't require cold storage requirements, regular old refrigerator. People get a sore arm, they get a headache, they get fatigue, myalgia, nausea, tends to last for a day or two. A lot of people do not get anything at all other than a sore arm. Most people do get a sore overall. The post-vaccination recommendations for observation are the same. So with severe allergies or history of allergic reactions needs to be monitored for 30 minutes, everybody else for 15. If you look at all of these together, on the left of that slide is the vaccine, Moderna, Pfizer, the J&J, AstraZeneca, which is another viral vector, Novavax, which is a protein, and Sputnik, which is a viral vector. And then you look over and look at the yellow, you see that they are all 100% protective against hospitalization and death after they've become active, which is 2 weeks after the doses overall. Great vaccines. We're very fortunate to have all of these. Next slide.
Although, Steve, we don't, just to clarify, everybody, we don't have all of them yet, right? We just have these top 3 so far.
Sputnik is actually being used, Sputnik's around being used around the world. It was actually just bought by several of the former Eastern Bloc, and I actually saw Italy's going to buy some of Sputnik. Also, AstraZeneca is being distributed in many different places, and England has used the most of it so far. Next slide. And I think the next slide, basically what's in the J&J vaccine. We've heard lots of things. I think the important thing is it doesn't contain all these things: coronavirus, aerosol, mercury, latex. It does not have polyethylene glycol. It does have polysorbate 80. It's got some salts and sugars, and it's got the adenovirus. Next slide. There has been some discussion in the news around fetal cell lines. The J&J vaccine was used in fetal cell lines that were actually been propagated since the 70s and 80s. It's used to grow the adenovirus, and the vaccines do not have fetal cells in them. They are developed, these, and as I think you can read the controversy, there's discussion about what that means in the Catholic Church. Next slide. What's important about this? It's a good it is an excellent vaccine. It's being rolled out. A lot of people are really happy to get this, and its efficacy for serious illness is as good as all the other vaccines in preventing serious illness and death. It's a single dose. There's no special refrigeration, and this will allow us to rapidly expand the number of people that we're vaccinating, which is exceedingly important as we all hear about variant. The increases in variants and types of variants around the world and in the United States. We've had a couple of our own variants, and we've had variants in Maine. Getting as many people vaccinated as quickly as possible is really important. This just adds to our armamentarium. What's the difference? If you look at this slide, it will show you kind of the major differences. What are they? One's an adenovirus vaccine. That's Johnson. It's a one shot, and its efficacy for serious illness, as we've described, for overall illness, it appears to be less. But recognizing that these trials were done at a different time in different populations, there are no head-to-head comparisons. They all appear to be good vaccines to have, and I think as I said, I think we're very fortunate to have all three of these and to get them all rolled out. So the recommendation is, what vaccine should you get? You should get the one that they're offering when you go to the clinic. Next slide. There's some new updates that this just came out yesterday from the federal CDC on what recommendations they're providing as of now. This will probably change over time, but for people who are fully vaccinated in non-healthcare settings, you can visit other fully vaccinated people indoors. What does this mean? You can have small family groups who are vaccinated. You can have your friends over who've been vaccinated and not have to wear masks. Otherwise, when you're going outside or in a population in which you do not know their vaccination status, you should continue to wear a mask. You do not need to quarantine after known exposure if you are asymptomatic and you've been vaccinated. Next slide, I think, also goes through some of those. So you take precautions in public. We're traveling in any potential exposure to people who do not know their vaccination status, and avoid group settings because you're not going to know that. Get tested if you are experiencing symptoms, even if you've been vaccinated, and follow guidelines by individual employers as they make them. This will continue to travel. CDC did not make any recommendations. They still recommend against travel at this point as a way to help control the pandemic. But we're going to get more experience over time, and as I said, I think it's taking small steps as we learn more and more about vaccine. Remember, we just started giving these in December, and we're just beginning to get more experience. Other updates from clinical considerations: if someone needs another vaccine of another type, whether it's a tetanus shot, a flu shot, or updates of Tdap or whatever, they should wait 14 days if they can. However, if the vaccines need to be administered within a shorter period and the benefits outweigh any potential risk, and I really want to emphasize there's only a potential risk for interactions between these vaccines. It's not been shown. This is just being exceedingly cautious. You could go ahead if you need to have it overall. If you have someone who's been vaccinated and they turn out to be COVID positive, we're following those. Federal CDC are following those, and some of those we're doing whole genome sequencing to look at their genetic makeup to see whether there's any variant reason or whether it's just a vaccine failure for that one individual. Most of those that we've seen so far, the people are either asymptomatic or mildly symptomatic, but just bear that. Let's see if that happened. There's the phone number. I think the next slide goes to Dr. Panoia.
Yeah, so Peggy, you available?
Coach,
Not hearing you yet, Peg.
Let me.
There we go. There we go.
Okay, so this is the update on the approach to immunocompromised people, so that they did include patients with HIV infection, so that they may be at increased risk for severe COVID-19. No data available to establish COVID-19 vaccine safety and efficacy in these groups, and people with stable HIV infection were included in the clinical trials, though the data on them remains limited. Currently authorized COVID-19 vaccines are not live vaccines, and therefore can be safely administered to immunocompromised people, i.e. immunocompromised people can receive COVID-19 vaccination. It's a non-replicating or replication incompetent virus that is given with the Johnson. Data currently are insufficient to inform optimal timing of the COVID-19 vaccination. However, based on general best practices for vaccination of immunocompromised people, ideally, vaccination should be completed at least 2 weeks before initiation of immunosuppressive therapies. And when possible, not to administer complete COVID-19 vaccine series in advance. People on immunosuppressive therapy can still receive COVID-19 vaccination. Decisions to delay immunosuppressive therapy to complete the COVID-19 vaccination should consider the person's risks related to their underlying condition. So again, if they can defer, it is better. And then antibody testing not currently recommended following COVID-19 vaccination. The clinical utility hasn't been established for testing antibody titers. And so this is the reference, and then, so then here's the new, based on the February 10th thing, people with a contraindication to one of the mRNA COVID-19 vaccines should not receive doses of either of the mRNA vaccines. So if they've had an immediate allergic reaction to their first Pfizer dose, for instance, they should not receive Moderna. However, people with a contraindication to an mRNA COVID-19 vaccination may be able to receive Janssen COVID-19 vaccine, and vice versa if they're allergic to Janssen vaccine, provided certain measures are taken, and that's in the precaution section of the CDC stoplight algorithm. Known polysorbate allergy is no longer a contraindication to mRNA vaccine, but it still remains a precaution, or it is a precaution to mRNA vaccination. However, known polysorbate allergy is a contraindication to the Janssen J&J COVID-19 vaccine, and thus a precaution to mRNA COVID-19 vaccination. People with a contraindication to J&J COVID-19 vaccine who have a known polysorbate allergy may be considered for one of the mRNA vaccines. And that is outlined on the following algorithm, the US CDC triage. And so just pointing out at the bottom, the appendix that indicates this, and that the contraindications are in the red box, the precaution to vaccination for polysorbate, or for Janssen, or for PEG for the mRNA vaccines. And while there is some cross-reactivity, it's probably pretty minimal, so they're treating them individually and separately.
Great, thank you, Peggy. And just to totally simplify it, so the contraindication is don't give it. Precaution is the 30-minute, then proceed. Everybody gets 15-minute observation. To completely oversimplify that. Super, thank you. I suspect we're going to have questions about that mix and match, or who can get what. So if you hang on just a minute, I'll just give quick updates on the updates from the state side of things. So folks know about the age-based strategy, which is a couple weeks ago, and then last week I mentioned the school teachers and child care staff that had just come out as a federal mandate from the Biden administration that is now adopted by the state. The key thing there for everyone to know is that the 3 commercial pharmacy partners between Walmart, Walgreens, and Hannaford, they've got about 100 stores with pharmacies offering, but those, because of that federal mandate about teachers and staff, those sites are now being dedicated to school teachers, staff, and child care providers, and they're only doing that. If your patients already had an appointment because they fit into the age band, they are not supposed to cancel those, but they're supposed to dedicate new slots only to that school childcare population. There is an exception that says if they have an unfilled slot 48 hours ahead of the appointment, they can open it up to others, and they're supposed to stick within the age band. But just FYI, the other vaccine providers, like all the big high throughput sites and other, hospital sites that are offering, are not, other than this weekend when they're holding some pre-scheduled vaccine clinics for 60 plus teachers, school staff, childcare, they're supposed to be offering access equally to the age band, the current age band, and the school childcare. So they won't be holding special slots or clinics. We also know that the federal agency HRSA is giving doses to 2 FQHCs, PCHC and Outreach in the state, which is great. Hopefully others soon as well. So that's just reflected in an updated version of my little schematic here. You've all seen this before, information always on the website, which has also been updated with the age bands and then the teacher information down at the bottom as well. And as always, we post the info to the website. So with that, I'm going to stop sharing and open up to questions and look to good Dr. Belisle, who maybe has been able to see them and tee them up.
Some of these have been answered, but I'll just throw this back to Dr. Panoia. I've heard some immunocompromised people say they don't want to get J&J because it's live virus. Could you please provide an accurate talking point? And I see Cheryl's already answered it. There's no live virus in J&J. I don't know if Dr. Panoia or Dr. Licky, if you want to add anything else.
Yeah, so it can't replicate. It's replication incompetent, is my understanding, right, Dr. Sears? I think.
Yeah, they actually take out the replicating gene, so then they plug in the spike gene from the SARS-CoV-2, and no, it does not replicate. So that's what keeps it safe. There are newer vaccines that we may see in the future which are potentially replicating, but those do not exist at this point, or at least have not been released.
Dr. Panoia, is it true that polysorbate 80 and PEG cross-reactive people with issues often have issues with the other?
It's actually not often, but it is a potential cross-reactivity. It is not invariable. So the different lengths, all of that can have a factor. So basically, there may be some cross-reactivity, and that is why the 2 vaccine types are still in the precaution category, even if they are not a contraindication. So for instance, if you're Janssen allergic, you're still in a precaution with the mRNA vaccine group to receive it, even though it may be safer for you because of this potential cross-reactivity, but it is probably it's probably low.
Dr. Sears, why is severe illness ranked as worse than hospitalizations?
I don't think it's meant to be that way. The hospitalization and death are the most serious endpoints that are being evaluated. I think one of the things is that in the trials there really weren't that many people who were hospitalized who died, but there were a lot of people with severe illness as defined, and so some of those are to look at the overall efficacy in the more complex disease from COVID. But again, there's no implication that severe disease is worse than death. I think that doesn't make sense.
Has there been any federal guidance from CMS or other agencies around healthcare workers, long-term care, those who are governed by the federal guidance with the new Maine CDC around those who have been vaccinated? Because that's been the issue, is the CDC puts out guidance, but the CMS doesn't, and so they're caught between the 2 regulatory groups.
Yeah, I've not seen anything from CMS as of yet. That things are changing fairly quickly overall. So the healthcare for quarantine for healthcare workers is different at the moment than for non-healthcare workers. And that's the healthcare workers working in a healthcare setting.
And to note those that new US CDC guidance that loosened up, the connecting, socially yesterday, very clearly, and I put it in italics on the slide, says for non-healthcare work or a non-healthcare setting. So unfortunately, not yet. And I think it's understandable. Everybody wants to be cautious around vulnerable people, but I suspect we will see that over time.
Residents in long-term care assisted living, they still cannot visit with vaccinated family members in a private setting? What's the long-term care guidance on vaccinated family members?
I have not seen that the long-term care guidance has changed as of yet.
But it's not quite true, cannot visit with
Okay,
vaccinated family members. That's not, I mean, if anything, right, the feds have really pushed on facilities do have to allow
right.
for visitation. So that's not quite accurate. And I know it goes facility by facility, but there are federal rules that say the facilities must allow. Now it is, the specifics are driven by the community rates and, um, uh, what's happening in a given region.
Yeah,
But
yeah. I think that, and I appreciate that, Lisa. I think that this continues to be a complex area with the intersection between CDC and CMS, and then what the community rates are overall, and now vaccination on top of that. So vaccination is just the addition, and how that changes things has not yet been clearly articulated in guidance.
Are NSAIDs contraindicated post-vaccine? They've heard mixed recommendations.
I'll jump
Dr.
into that one because I know we said different
Yeah,
things on this one, but I specifically saw in that clinical consideration, the US CDC one, it lists them as, so it's nothing preemptive, right? Not prophylactic, but it includes them in the list of what you could do for mild symptoms afterwards. So I don't know if there are clinical other thoughts about that, but I did note that on the US CDC site yesterday.
Dr. Panoya had some an article that I think she sent around where there's some research studies that suggested NSAIDs might downregulate an immune response, but that study did not seem to say there was any problem with it. So I agree, Lisa, that if people need something after the vaccine, they could use either acetaminophen or NSAIDs is from, at least that's on the CDC website.
So a couple questions around the teachers. It's for child care workers and then pre-K to 12th grade. It's not for higher education right now. And in terms of the age banding, the governor had announced this coming weekend there were going to be special clinics for school staff who are age 60 and up. And those have been arranged with most of the major hospitals, health systems, some EMS locations to do the 60-year-old and up teachers this weekend. But those special clinics are special. And like Lisa said, otherwise the teachers are being directed to go to the pharmacy program, the federal pharmacy program, because there's different streams of vaccine supply coming in. So the state is prioritizing 60 and up with the state supply, and the school staff is being prioritized at the federal pharmacy supply. Saying that, if there are open appointments at the major vaccine sites, they would be open to those 60 plus and the school staff folks, but there should not be prioritization of, there should not be special clinics set up for all the teachers in a school at this point, because the federal supply is really what should be accessed first for the teachers in all the ages. So that's, I know where the clinics are getting overwhelmed right now with calls, but they should be directing the teachers under 60 to the federal pharmacy sites first. There is a little bit of a lag in that policy from when it was announced Wednesday before the pharmacies are going to have enough appointments and vaccine to do everybody. But by the end of the month, the hope is that there will be enough vaccine coming in through the federal pharmacy to get to all the teachers and daycare workers. So it takes a little bit of time to get the vaccine in. So the other question is, how are places dealing with those who wish to avoid J&J for religious reasons?
So I'll jump into that because that's come up in several discussions. I mean, so we included, the talking points in the slide set here. If it comes up, in discussions with patients. And I think it's emphasizing that, everybody needs to make their own decision. But, people aren't generally, some of the comments from some of the religious leaders has been, if you get a choice, well, you don't get a choice most places. And as Steve said, the best, and Dr. Shah is fond of saying, the best vaccine is the one closest to your arm. I think the strategy I've suggested with groups is to try to get public support from their local leaders and their religious leaders to make public statements that, they encourage people for the good of the community to get vaccinated with whatever vaccine is available. You can get into the finer points of there are no actual fetal cells in the J&J, but that gets hard after a certain point. Ultimately it's up to people's decisions. And I think if it's a one-on-one setting is different from a public setting. And you have to, sort of figure out what's going to be the best approach and tactic at the time. But anybody, is Laura on, or anybody else?
Yeah,
want to
the only
figure
other
out?
thing I'd add to that is that a lot of places only have one vaccine that they're giving at one time to maintain logistic integrity and make sure that they're not, sometimes they've got second doses for people. And so it's a lot of places, J&J is all they have. And again, that gets back to it's a very effective vaccine and being offered in a number of settings.
And when people, call or go online to book their appointment, they're not going to know. There's no way they're going to know which one they're going to get. So for the most part, I mean, some sites, again, to Steve's point, are only doing one, but for the average person in the public, they're not going to know, which one is doing which. So.
And for the J&J, you've probably heard Dr. Shaw say there was a lot of J&J that came in over the last week to the state, but after that supply is currently used up, the state is unclear when additional J&J is going to come back into the state, and it may not be to the end of the month or April. And so I see there's some questions about, are we prioritizing J&J for different populations or groups? All the J&J has been distributed out through the state that the state currently has right now. And so we're just not sure when the next supply is going to come in. And then maybe those conversations will happen, but it's all out there right now. I've heard some of the theoretical concern about vaccination of immunocompromised patients with emergence of variants, weak immune response to vaccine, provides evolutionary pressure for variant emergence. They're not sure what actions are advisable, but at a minimum, should immunocompromised vaccinated folks maintain mask distancing, et cetera. I don't know, Peggy, if you have thoughts around that, or Cheryl, Dr. Sears.
Well, I think, I'll start out. There's a lot of concern about variants developing in people who do not clear virus. And so without even looking at the vaccination question, there's some data that suggests variants developed in people who are immunocompromised, who got infected, who then got cleared. So is a vaccine better than not? Probably yes. And maybe it'll actually decrease that pressure overall. I don't know of any data on that specifically. And again, I think that people who are severely immunocompromised would probably want to continue to mask.
Dr. Onion says they saw an 80-year-old with complaints of cognitive fogginess 10 days post-second Moderna. Any action needed, or any thoughts on that?
I've not heard that complaint before, and I've not seen it written.
Are there any shortage of vaccinators in the state now that supplies are improving? I saw Peggy put in the Maine response for volunteers. There's definitely a need for vaccinators. If you're in Maine response, they put out a call last week or last 2 weeks to see who is interested. There's specifically some in the Lewiston, Auburn area, and there's some sites that are particularly looking for vaccinators. So yes, Lisa posted the guidance. And Terry Ann also mentioned that they saw another kind of diagnosis post-vaccine, which is unclear if it's related. So I think that's.
Well, and for all those, people should certainly always consider reporting things on VAERS, right? I mean, anything you see, and then they can, that's the whole idea, right? They're tracking those and can see whether there are trends. And if patients are using the VSafe themselves, certainly reporting symptoms that way. And there we go. It's 8 o'clock. Wow. It magically disappears. Thank you so much, Peggy, for jumping in. Steve, as always, everybody for joining us. We'll do a retake on this one on Friday, and then another round Tuesday. We just, FYI, we will likely be backing off to twice a month, either the end of this month or 1st of April, as things, with hope, fingers crossed, start to settle down. So we'll let you know. Right now, we're going to keep it weekly for a little bit longer, but we'll update you as we go. Thanks, everyone. Bye-bye.